Good morning to all of you who have registered for today's webinar, which is jointly conducted by the Medical Travel Company and ourmedic.com. Just a few housekeeping rules before we begin. Please keep your cameras on if you can and stay muted during the session. This webinar is being recorded, so please bear that in mind. Choose speaker view for your best experience, and please add your questions to the chat box. I will take all the queries at the end in the question and answer session. And we hope that most, if not all, questions will be answered during the course of the presentation today. And it gives me great pleasure not just to welcome all of you, but also my panelists for today, Dr. Rima Rajkhowa. Hello, Rima.
Hello.
Hi, who is a consultant and subspecialist in reproductive medicine, and she's representing the Medical Travel Company, UK. Dr. Sandeep Talwar.
Hello.
From Nova IVF, who's representing the Medical Travel Company, India, and Dr. Bhavika Vagani, who is a GP and lifestyle medicine expert from the Niva Clinic, London. I am moderating the session today, and I'm Dr. Vinita Manjure. I'm a GP in UK, in Bedford, to be precise. And obviously, because I've had loads of experience in obs and gynae in my early years, my areas of special interest are women's health and endocrinology, among some of the others that I have developed. I'm also the director of ourmedic.com, which is an online platform which has a three-pronged approach. We offer second opinion to patients who are in India with doctors who are in the UK. We also provide services to TMTC, where we provide services of specialists and GPs for patients in the UK who wish to travel to India. And we also offer UK to UK consultations, doctors in the UK, patients also in the UK. So why are we here today? So 25th of July each year marks the World IVF Day. And this is to commemorate the birth of Louise Brown, the world's first test tube baby who was born in 1978. That was magic at the time. The WHO report on global fertility estimates, which are based on the data from 1990 to 2021, and the report was published in 2023, states that a lifetime prevalence of 17.5 for infertility and a period prevalence of 12.6%, which simply translates to 1 in 6 couples experience infertility at some stage of their lives. This obviously is colossal. And it's only right that we deal with this subject very sensitively and offer every couple a fair chance to achieve a pregnancy, even if it needs to be assisted using modern medications and techniques. And on that note, I open today's webinar. Let's talk about infertility. And my first question is to Rima Rajkhowa. Many couples wonder why pregnancy isn't happening as quickly as they hoped. Would you please walk us through the most common reasons for infertility in both women and men? And when would it be the right time to consider seeing a fertility specialist? Over to you, Rima.
Thank you, Vinita. That was a very compelling data that you presented. And as you have said, 1 in 6 couples in a room may struggle to conceive either for the first time or even for subsequent pregnancies, having had a healthy pregnancy and live birth previously. So subfertility is probably the best term to use because very few couples are actually infertile. Most of them are subfertile. And we say that 85% of couples should conceive within a year of trying and 92% within 2 years of trying. And therefore, the Royal College of Obstetrics and Gynaecologists has suggested, have produced guidelines which have said that if you are younger, say less than 35 years of age, and you have not conceived within 12 months of regular unprotected intercourse, then it would be appropriate for you to consider seeing your doctor, either your GP or a specialist, to try and understand why there's a delay. If you are older, more than 35 years, then it is, of course, important that you look into tests and investigations to see if there's any reason earlier. And generally, we'd say if you're more than 37, you should probably start looking for answers after 6 months of regular unprotected intercourse. And of course, these days, we also have another group of patients who are same-sex couples, or they are single women, and they, of course, can begin their investigations when they think that they're ready to start a family. So with this background, we ask 3 questions. Is the woman ovulating, and does she have a good store of eggs in her ovaries? Number 2, is the man producing sperm, which are in good numbers? Are they swimming well, and is there a normal morphology or shape? And thirdly, we ask, is the pelvic anatomy normal? That means, are the fallopian tubes open? And is the uterus normal in size and shape, or is there any structural problems with the pelvis? So the tests that we recommend are, number 1, a semen analysis. That is always the first test to be done to exclude and make sure that the sperm parameters are normal. Secondly, we do a blood test to check for ovulation. You can do that around day 21 if you have a regular cycle, though it is said that a regular menstrual cycle is perhaps a good surrogate marker for ovulation. Thirdly, we always do a test to check the store of eggs. On the NHS, we offer a hormone profile called FSH-LH, which is done between day 2 to 5 of a cycle. But realistically, those tests are not very sensitive. So we would recommend a blood test for a hormone called AMH, or anti-Mullerian hormone. This is a growth factor which tells us the store of eggs much more accurately. So semen analysis, blood test for ovulation, an AMH blood test, and a pelvic ultrasound scan. These are the 4 basic tests. And finally, if all 4 are normal, then we also do a tubal patency test, which can be an X-ray called hysterosalpingogram or HSG, or with a scan called HICOSY. So I have put forward here a little pie chart. When we have all these tests, out of 100 couples that I would see in a clinic, 30% there would be a male factor, and that's a significant number. In others, there will be an ovulation problem in 25%, and the commonest cause is polycystic ovary syndrome. Then in another 25%, it may be tubal damage or fibroids or endometriosis or other pelvic anatomical factors. But a very large proportion, 15 to 20%, we will find no obvious cause, and that is called unexplained subfertility. So once we have done the test, it's very important that we explain the results to the couple and tell them this may be a possible reason for the delay. And it is very important for us to remember that there can be more than one factor. In fact, in 60% of couples, there may be a male factor with an ovulation problem, or a tubal factor with a male factor. So there is always a chance there's more than one factor. And it is very important also to be able to reassure them if nothing is wrong.
Thank you very much, Rima. That was very useful. And I hope our audience has found these statistics to be very significantly useful to them as well. The next question I would like to pose to you, Rima, is we are seeing more and more couples delaying pregnancy well into their 30s and even 40s. How exactly does age affect fertility? How does it impact on the quality of eggs? And what options do patients have if they would like to preserve or improve their chances of achieving a pregnancy?
Vinita, that's such an important question. So can I show the next slide? So age is becoming a really important factor to consider. This is societal changes. Women are starting their careers. They want to delay starting the family. They may not have found the right partner. And because of societal changes, there has been a shift in the age when people wish to start their family. But this, unfortunately, has got consequences. This slide shows a very well documented studies where it shows how the store of eggs declines with age. And if you look at this curve, when a woman is born, she's born with a fixed number of eggs. A man produces sperms every 3 months. But a woman, she's born with 1,000,000 eggs at birth and then no more. And it just starts declining. By the time she starts her first period, it's down to 500,000. By the time she's 35, there has been a steady decline, and now there's a sharp decline. And after the age of 40, there is a really sharp decline. And by the time she is 51 years of age, she has 1,000 eggs left in her ovaries, and she has no further periods. And unfortunately, this cannot be reversed. You cannot say that I'll go on the pill and I'll stop this decline. You can't. This is nature, and you have no control over it. So this is quantity. The quantity of eggs decrease as we grow older, and there's a sharp shift down after the age of 37 and certainly after the age of 40. Next slide. But in addition to quantity, the other problem is quality of the eggs. As we grow older, there are more chromosomal abnormalities in the eggs. That means the little elements in our eggs which carry the DNA become damaged. And that is noted in this slide. As you can see, after the age of 35, it rises sharply. And after the age of 40, almost 75% of the eggs that you release each month will have a chromosomal abnormality. And what does this mean? So your quantity is lower, your quality is poorer, so your chances of pregnancy become lower, and sadly, the risk of miscarriage increases from about 15% at age 35 to almost 30-40% at the age of 40 and even higher as you grow older. So age has a huge impact on the way we have, on our ability to have a family or grow our family. So one of the options, as you've mentioned, is fertility preservation. Next slide. So you can see that, next slide, please, that this is the data from HFEA, our regulator. And you can see here that the number of patients who are getting older and having treatments has jumped in the ages of 40 to 44. In 2000, only 4% of women were having IVF treatment at that age, and now it is 11%. So the older women are coming for treatment, and they are coming later. And what does that mean? Next slide. Unfortunately, though they're coming later and they're having IVF as they want to, the pregnancy rate is almost half of that of a younger woman. But it doesn't mean you can't get pregnant, and it doesn't mean you mustn't try. And of course you must try, and we will support you, but we just have to have realistic expectations. Next slide. So this slide, I think, explains very clearly that the red line is showing us how the pregnancy rate for IVF treatment, which probably reflects what's happening in nature as well within our bodies when we're trying to conceive naturally. It begins to drop after the age of 35, and after 40, the pregnancy rate is about 10%. And by the time you're 45, 46, it's almost not there. But there is an alternative which we can offer, which we will be talking about later, is treatment with donor eggs, where you will maintain the pregnancy rate of a younger woman because you use the eggs of a younger woman. So I just wanted to show this slide that age has an impact only on the ovaries, not on your uterus. And if you remain a healthy woman, there are options for you to have a healthy pregnancy at live birth. Besides, of course, you can store your eggs when you're 35 and use them when you're 40, 45, and you will have the pregnancy of a 35-year-old. And that is the beauty of fertility preservation and egg freezing, which I think a lot of young women are considering when career is important. And this slide just shows that your eggs at 35 will give you the pregnancy of a 35-year-old when you use it at the time when you're 40.
No, yeah. I'm sure this was like music to a lot of ears. And on that note, may I ask Dr. Sandeep Talwar to come in to talk to us about, how it is to have donor eggs and whether that service could be made available in your unit in India? You're muted, Sandeep. would you like to take this question now or a bit later? You're muted. You need to unmute yourself, please.
Yeah, I have
Karan, yeah,
unmuted. I have unmuted. So
yeah,
can you
okay,
please
thank you.
repeat the question again?
So my question was based on what Rima just said to us. Would you be able to talk us through what the options are for women who are either wanting to delay the pregnancy or are already at a later age now and trying to conceive through the process of IVF? What are the options available for them? And particularly if you talk us through what is available at your unit, that would be most useful.
So, yeah, good morning. So, the options are two: fertility preservation, as Dr. Rima told you, that you could freeze your eggs, or you can go for donor eggs. So, donor egg IVF is that you select younger women, you screen them properly, and you stimulate their ovaries to yield eggs and use those eggs. Naturally, as Dr. Rima showed you charts of pregnancy rates in with how they decline with age and how chromosomal abnormalities increase with age. So if you are using eggs from donors who are younger ones, so your pregnancy will be more, your miscarriages will be less because your chromosomal abnormalities also decrease if you are using eggs with the younger women. So that is an option for women who, for some reason, cannot go for their own eggs because of declining in fertility and increased chromosomal malformations.
Thank you very much. Yeah, that was very useful.
Mm.
I now move over to, I think somebody's talking. If they can mute themselves, that would be great. Okay. So this question I'm posing to Dr. Bhavika Vagani for couples who are, hello Bhavika, if you would
Hi,
like to
can you hear
unmute yourself.
me?
Hi, yes,
Hi.
we can hear you. So the question was for couples who are planning to start their journey towards achieving fertility, how important is it to prepare your body
I
for
think it's
pregnancy? Yeah,
Yeah,
and what
no, I
would
think very good question. No, very good question. I think it's vital. The best way I can describe it to my patients is like a garden. If you want the garden to flower and blossom over the summer, the preparation has to go in at winter and at autumn. So the same way to prepare for IVF, I think 6 months, even 12 months before you're planning to have the treatment, it's very important to optimize your body. So, optimize the vitamins, the nutrition, the sleep, the exercise, whatever that may be. It's very personal and individual to each person, and that does need to be optimized so you can have the best outcomes. Because if you're not sleeping well, your cortisol level, which are your stress levels, already will be high because you're going through something like this. So I think having all of that in balance, including the nutrition, will be really helpful. A bit like you put the fertilizer into the ground, you put the right seeds into the ground, and therefore in 8 to 9 months, when finally it is time, your body is prepared. So I feel like this is an invaluable component of the process, which I think a lot of people overlook actually. So it's something that I'm trying to bring into the practice a bit more now. And I think people are beginning to realize that that wellness journey is really, really important.
Oh, thank you. Thank you very much. So what I'm hearing here is factors like lifestyle choices, diet, exercise, stress management all have a role in improving fertility and the outcomes, even if you go down the route of using technological supports
I
to
agree.
help with the pregnancy.
Yeah,
Okay.
strongly. Yeah. And there's more and more research that is supporting this as well. So yeah, exciting times in this field.
100%. Okay, I now focus my attention back to Dr. Rajkhowa. So, Rima, one of the most common questions most couples have is when is IVF recommended? And could you walk us through the typical conditions where IVF becomes the most appropriate treatment choice? You are muted, Rima.
So thank you, Vinita. So obviously, all of us here and all the patients themselves and all of us clinicians want that the couple should conceive naturally. And I would like to reassure that quite a lot of couples will reassure naturally even after they've seen us. But then if they have not, then it's important that they consider the most appropriate treatment at the most appropriate time. So we have the NICE guidelines. The National Institute of Clinical Excellence in the UK has given us some guidelines as to when IVF should be recommended. So first and foremost, if you have a blocked tube or you have a sperm parameter which is abnormal, or if you have problems where ovulation induction treatment with tablets has failed, then of course the first choice then will be straight away to consider IVF, which is in vitro fertilization, with or without ICSI. ICSI is where we inject the sperm into the egg, which is also just an additional step in the IVF process in the laboratory. If you have no obvious abnormality, and we say you have unexplained subfertility, then the National Institute of Clinical Excellence say that you can wait up to 2 years because 80% of couples may conceive. However, NICE has not given the clarification as to what you do in an older woman. Because if you are 37 and you have unexplained subfertility, and you wait for another year to make it 2 years and you're 38, your pregnancy rate has dropped from 35-40% to 25-30%. So I would say that even if you have unexplained subfertility, after a year, depending on your age, if you're young, you can wait for 2 years. Young, I mean less than 35. But if you're more than 35, then I would say if you have not conceived within 6 to 12 months, it may not be inappropriate to consider IVF treatment with or without ICSI. In addition, there's a caveat that if you have a low store of eggs, a low AMH, now it's very important that I say very clearly that AMH is not a predictor of live birth. A low AMH does not mean you will not get pregnant, but it does mean that it will keep dropping with time. So if you're older and you have a low AMH, then it is important you go sooner rather than later because it will have an impact on your pregnancy rate in the future. But even if you have low AMH, you have IVF treatment, and we have a good quality embryo, your pregnancy rate will be like that of a woman with a normal AMH for your age. AMH is different at different age groups, and we know what those levels should be. And we as specialists in the field will be able to give the advice, yes, this is okay, and this is not so okay. Don't panic, it's fine. You can still have a baby, but maybe we consider treatment sooner.
That was very helpful, and I hope it answered a question for a lot of people. We know that many couples in the UK, and I have all regards for the NICE guidelines, but that does mean that we face long NHS waiting lists, and this can be quite detrimental to a lot of couples who are seeking treatment for their subfertility. We are aware that there are private clinics in the UK, but they can be quite expensive. In this context, what could be the other viable options that couples could consider?
Thank you. So, Vinita, at the start of this meeting, you talked about the WHO report, which was so impactful because it said very clearly that whether you're in a high-income or low-income country, the subfertility rates are about 17.5%. And one of the main things that the report did focus on is the affordability of IVF. Now, IVF is available on the NHS in UK, but it is very limited and the numbers are dropping. The recent HFEA report showed that it has dropped by 10%, the ability to have NHS funded, and there are strict eligibility criteria that have to be met. So a lot of patients will need to consider paying for their IVF treatment themselves. And that is something, unfortunately, that can be, the cost can be very variable and it can be very high. And there are many clinics who charge for extras, etc. So one of the options that I would like to discuss here today is, over and above having self-funded treatment in the UK, we hope to offer at TMTC the option of having treatment in collaboration with a clinic in India to see if we can make this more affordable with the same degree of clinical and laboratory expertise and significantly better availability of, for example, Asian egg donors where ethnicity is important, and have similar success rates. And I think the USP for this pathway is that you will have pre-treatment consultation and a UK named consultant. You will have a named consultant in India where the clinic has been matched to our standards, and we will be working collaboratively with consultants like Dr. Talwar, who are very good and experienced and highly regarded in their field. And once you've had treatment, you come back to UK and you have the aftercare. Now, couples have been traveling to India for many years now, and one of the main issues have been that when they come back, there is no one to look after them, no one to give them help, support, advice, and we are addressing that. And we are ensuring what the HFEA has pointed out, that regulations are variable, and that's why we're working with partners in India where we know the regulations are strictly followed, and the patients will be safe. They will have cost-effective treatment, which is affordable to them, with personalized care and the ability to know that they are being looked after in both countries.
Fantastic. That sounds not just reassuring, but also extremely encouraging. My question would it be possible for them to then start their journey for going through IVF in India in the UK? Can they consult somebody here?
Absolutely. So they would consult somebody like myself who has worked for more than 25 years as a consultant and clinician in this field, in this country, in all areas, both in the NHS and private sector. So they would have a thorough discussion of their options, confirmation that it is appropriate for them to travel, confirmation that this is the treatment of your choice, then a linked consultation with my Indian colleagues like Dr. Talwar, and then we can make a treatment plan which they can begin while they are in the UK, so that it shortens the time that they have to stay in India, and they are confident in who they can access to here. So yes to answer your question, they can see a consultant here and begin their treatment here before they leave for India, which will be supervised.
That's brilliant. So now this question, I would like Dr. Talwar and Dr. Rajkhowa to almost answer in tandem, and that would be take us through the patient journey with TMTC, both in the UK and how it pans out in India as well.
So I think
Well, let Dr. Rima say.
No, so
Yeah.
Sonu, I have started the Indian journey. Now I'm handing over to you.
Yeah.
So you would have an initial consult with Dr. Rima, and she's going to decide as to what exactly you need and what are the investigations you need, what is the pre-treatment medication you need. So she would have done everything and would have thoroughly worked you up and prepared you for the journey, which is really, really important. Because unless you are very clear about what has to be done, things will go on wrong. And we have we have a coordination with each other. So after you have been evaluated and we've had a detailed consult both with her and me, then you come to India completely prepared. And that's how it spans, so that there are no loopholes. Your pre-treatment has been done, your treatment gets done here in India, and then after the treatment there is somebody to handhold you there in England. So everything, the whole pathways gets completed without leaving anything, any loopholes anywhere in the treatment or the journey of IVF anywhere.
No, that's very useful to know. And on that
Vinita,
same,
may I just, sorry
yeah,
to
sorry,
interrupt you,
go on,
Vinita, may I
Rima.
just
Yeah.
add in one little thing? I also just want to highlight that the TMTC pathway also has a concierge service where there will be a place where you can stay if you need to. There will be someone who will support you in the journey. There can be an add-on wellness package so that We know that stress, Bhavika has explained, that stress plays and anxiety plays a very important role in how successful your treatment can be. And we have the support, the wellness, the linkage, everything to make your journey smooth. And in my experience, the same embryo in a woman who's stressed will give a lower pregnancy rate compared to a woman who's calm and laid back and is just completely relaxed through the journey. It makes a huge difference.
No,
Exactly.
that's very useful. That very useful to know. And my next question, of course, is to Dr. Sandeep Talwar. We have had couples who have had a hesitancy in going to India for treatments such as this because they have always been worried about the regulatory framework. Would you please take us through what the regulatory framework in India is and what do you practice in your, when you treat patients with IVF?
So we have very strict regulatory regulatory boards here in India. There is a ART board which certifies you whether you can do IVF, you can't do IVF, who are the ones who get, and you have to be registered, you have to be recognized. So we get registered with the ART, as like me or somebody else who has around 30 years of experience is level 2 consultants. And we have regulations for doing IVF ICSI or patients who go through the donor eggs, who can be the donors. You can only donate once. We have ways to verify those donors through their Aadhaar card. There is a portal through which we verify them, and we verify all the credentials. They should have never donated the eggs before, and all the investigations have to be done and everything, and how much you can stimulate, what are the things. So it's all registered, and we have insurance for all the papers are made, legal papers are signed. Only after everything is completed and all the paperwork is done and the all the regulations are adhered with, do you go forwards. I'm not saying it's only for people who come from England, but even our Indian patients. First, we have to do we have to go through the regulatory board. You have to meet all the guidelines. You have to see that the legal things are okay, the medical things are okay. Only then will you start a donor egg, donor program. You don't do like that. You can take time, you can cancel donors, but unless every condition is met with, you do not start it at all. We are very, very clear about it, and that's the way it works.
That's very good to know, and I'm sure this has reassured a lot of our listeners. What about the success rates at your unit, and how does it compare to success rates in the UK, for example?
So in our unit, we have success rates anywhere starting between 50 to 66% around. And I'm sure Dr. Rima will endorse that these are the success rates even in UK. And
Yes.
so, yes, so she can reiterate what I'm saying. These are the success rates you have. And we have very few miscarriage rates, which is again very reassuring, because once you go through this journey, you don't want a miscarriage. Neither of us wants it. But with a donor egg, since the quality of eggs is better, so the rate of miscarriage also comes down. It's all related to your chromosomal structure. And so the miscarriage rate, especially which we have, is very low where the donor egg program is concerned. So that's how it is.
Okay. No, that's
So
that's really good to know. Before I move on to the next question, I would ask the audience to put in any questions they have in the chat box, because I will take all those in the question and answer session of the webinar. Thank you. Okay, so with that, it takes us fairly to, and again, I'm looking at Rima for taking this question. What is the affordability?
So yes, so affordability is one of the factors that has brought this whole process in place, because we feel that one of the big things that patients struggle with is the cost. Now, we have looked at the evidence and we have looked at what kind of treatment that our treatment should be evidence-based, that we offer treatment to patients which we know is confirmed through studies and literature and trials to give effective treatment without adding on unnecessary add-ons which can increase the cost of treatment. So the cost of treatment is usually going to be very much lower. So the is going to be very much lower, and it is thought to be about 50% lower than the cost in the UK. You have to, of course, look at the implications of traveling overseas and the cost it may have in your time away from your place of work. So hence we have tried to incorporate beginning the treatment in the UK so that you don't have to spend a lot of time in India, and we have streamlined that to and made that as personalized as the couple would want it to be. So if you ask me for a number today, we will be able to give a personalized cost estimate to every couple who want to know that even well before they start the journey, so that they know that what exactly is on the table. And one thing that we have tried to absolutely ensure is that there will be no hidden costs. And this is very, very important to us, that what the cost estimate we give them at the outset is what they're going to have to check whether it is affordable for them. There will be no hidden extra costs added to their plan at a later date. May I just add one more thing about what Dr. Talwar has said? The pregnancy rates quoted by Dr. Talwar and the clinics that we have spoken to is about 55 to 66%, which is very, very good and definitely comparable to the success rates here. And that is with one attempt. And we know that sometimes couples may need more than one attempt because it's never 100% straight away. So we have something called frozen embryo transfer packages, which can be added on to the same cost of the initial one, which are less expensive because you already have the embryo. And that can be then that can reduce your cost to a great degree. And we have the information that most of the clinics will have spare embryos to freeze once they have created the embryo. So that gives you a second chance of another 45-50% chance of having a baby with the same cohort of donor eggs.
Excellent. No. So on that note, and I'm conscious of time, I'm going to go on to the question and answer session now. I will take some that have been added to the chat box, and we have a fair few questions that have been sent to us when people registered. So I'll go through them. And one of the, and I think that's a very good question. Are there any medications that cause male infertility? And does low libido have a direct impact on male fertility?
So medications and male subfertility. Yes, if you are taking over-the-counter medications like anabolic steroids or bodybuilding testosterone supplements, or sometimes even some protein supplements, etc., they can affect male subfertility. If you are a cannabis smoker, it will affect your subfertility. So it will affect the sperm count, motility in all ways. And there are some specific medications which is too long a medical list for me to put in here. They can affect sperm counts. So I would say, are there any medications that cause male fertility? I would say that there are lifestyle supplements that patients can take that can have a significant effect. There are some other medications that may have an effect, maybe not directly, but because of the general poor health as well. Low libido by itself doesn't cause male subfertility, but of course it will reduce the frequency of sexual intercourse and hence can affect natural fertility, but it will not cause a problem in conception following IVF ICSI treatment.
Thank you. That's very useful. And I hope, Shubham, that answers your question. The other questions that we have had, and I'll take them one by one. How long do I need to stay in India for an IVF treatment? And
Dr. Talwar.
Yeah. So, what is it? If you're looking at donor IVF, then we have two kinds of things. So you could at the most, you will not be able to, required to stay more than a month, is what I can tell you.
Okay, that's very useful. This is
Mm.
another very interesting question. And what is your advice to patients exploring Ayurvedic or homeopathic options? Can this be carried out in conjunction with the allopathic treatments that you offer?
Well, we in India get a lot of patients who say that I am taking some Ayurvedic medicines and homeopathic, as long as they are from people who are, right people who are genuinely giving you Ayurvedic and homeopathic medicines and not mixing steroids and other things in them. The only problem with Ayurvedic medicines and homeopathic is that where are you sourcing them from? If your source is authentic and you are actually getting the Ayurvedic or homeopathic, it's fine, but sometimes they mix all kinds of other things. That is the thing which troubles you. As Dr. Rima told you about anabolic steroids and all, the scare with you is that you have to source it from a place which is a very authentic place. So that's what it is.
Okay. One other question was, is there a chance of anyone over 45 to have a successful pregnancy with their own eggs? I think we did allude to that during the presentation, but if we want to take it, take the question again, please.
So I would never say never, but I would say extremely low chances, as I have shown in my slide. 43, 44 probably is about 5% chance of a pregnancy in live birth with your own eggs. Whether you have a good AMH or a low AMH, it doesn't matter. It's the quality of the eggs. By the time you're 45, 46, in my experience, you hardly ever respond to the drugs we use for IVF to get eggs. The quality of the eggs is very fragile. And if you do get an embryo, the chances of having a chromosomal abnormality in that embryo is almost 95 to 98%. So the chances of a pregnancy and live birth after the age of 45 with your own eggs is, I think, sadly, quite difficult.
Okay. And then there are other questions with almost very similar trends. If I have a low store of eggs, can I still have IVF with my own eggs? I think you've answered that question. If I have PCOS, can I still get pregnant with IVF?
You
Yes.
can, 100%.
Yeah. How will my IVF treatment be managed if I have stage 4 endometriosis?
So it depends on the structural anatomy, and I think this is a very personalized response. So the accessibility of the ovaries, the store of eggs. But all I can say is that yes, it is possible to proceed with IVF treatment with a stage 4 endometriosis, but the management plan would be somewhat different to standard IVF.
Okay. Next question is, will IVF always result in multiple pregnancies because of the number of embryos that are transferred? And perhaps Dr. Talwar should take this question.
Well, normally, in with the blastocyst transfer, you either transfer one blastocyst, and unless the patient says we want two blastocysts, we only transfer one. So the chances of multiple pregnancies are negligible with that, unless that one splits into two, which is very unlikely. Otherwise, most of the times you get single pregnancies only.
Okay. No, that's very useful. I have had previous failed IVF cycles. Do I still have a chance of success?
Yes. Depends on what was the cause of your failure. So that has to be evaluated properly. What was your IVF stimulation like? What was number of eggs you got? What was the number of embryos, quality of embryos? What was your husband's semen parameters? Anything which affected your uterus? Was your uterus healthy? Any infections, any fibroids, any other things which were there in the uterus to hinder the implantation? So everything has to be looked very closely, evaluated, and seen why probably you failed. And and you normally do get a reason why the IVF didn't work.
So
Yeah.
just to go back to that question, Vinita, again, just to add on to what Sonu has explained very nicely, is that when you have failed IVFs, if you have 2 or more failed cycles, we call it recurrent implantation failure. And then there would be a very systematic approach to the cause of the implantation failure. And as soon as Dr. Talwar has explained, it could be many factors, and we would try and address them. And so it is not a contraindication for having treatment, but it may mean a more personalized approach to try and improve the chances of implantation.
Yeah. Gina, does that answer your question? Give me a thumbs up, or you can unmute yourself if you wish to say anything at this point. There's also a comment, more than a question. There's a comment and a question here from Dr. Sukhdev, which says it's common nowadays for career women to focus on work in their early days, even delaying relationships. This will affect fertility. Yeah. What can we do to help spread the important message to consider this in their decisions and even preserving fertility in advance?
So, first of all, yes, it's a very important question. And I think that the importance of age is at least being spoken about much more than it was 4 or 5 years ago. So it starts with, I think, educating children when they are, children have been educated on contraception right from the time they're in school. Perhaps from starting from university levels, we should start education of both men and women to understand how fertility is impacted by age so that people are knowledgeable. And then when a couple come to see their general practitioner, perhaps it should be one of the common questions to ask a woman, are you planning a family? And perhaps this should become into GP education and training as well, to say that people ask the question that if you're not planning a family, this option is available. And perhaps more webinars of this nature to talk about fertility preservation, open it to the public, open it to doctors. So there's greater awareness. So we have to spread the awareness. It is coming, but slowly. We just need to increase it. So the HFEA data, which was published earlier this year, has shown the biggest jump in fertility sector has been in the field of age-related fertility preservation. There has been almost a 37% jump, but people are coming too late. I have patients coming at the age of 40 to store their eggs. That's not going to work. It has to be less than 37, ideally less than 35, that you come to store your eggs. And if you come after the age of 37, those eggs are very unlikely to give you a live birth.
Excellent. No, that's a very useful information. Bhavika, this is a question for you, perhaps. Does my weight impact my chances of IVF success?
Yes, we know that studies suggest that above a certain BMI, your cycle starts to change. It affects your female hormones. It can result in irregular menstrual cycle. It can result in no menstrual cycle. So there is a huge, when I was talking about the lifestyle medicine part of it, I was talking about weight loss as well and being an optimum weight to prepare your body for IVF. So we're doing a lot of work with patients at the moment to make sure that their BMI is within the normal range. And if I'm not mistaken, Dr. Mother Rima will also be able to support that above a certain BMI. I think IVF, the chances of successful IVF reduce significantly. And I think in some cases, IVF is contraindicated as well, if I'm not mistaken. So the weight it has a huge contributory factor. And I think not just for the IVF, but during pregnancy, a high BMI or carrying significant weight can have all sorts of complications, including preeclampsia as well as other things. So yes, very, very important.
No, that's very good to know. I think we've almost come to the end of all the questions. There was a comment when from one of the registered individuals, and that was a comment about 6 years on and we are still trying. So I guess this is hope for a lot of such couples. There's one more question which I will take because I'm just conscious of time. It's 11:53 now. Which drugs are needed to start in the UK for the IVF journey abroad? And are these easily available on the NHS via the GP or on private script? I think this is
So
an
it
important
depends.
question. Yeah.
Yes. So it depends on the kind of treatment the couples are traveling to India for. So if it is IVF with their own eggs, then they will need a hormone called FSH injections that they will need to start before they travel. Now, these will not, as it is a private treatment, this will not be available to them on the NHS via the GP. And we will be able to provide them with lists of pharmacies or where they can source them a little bit cheaper. But it is a private prescription for a drug, which can be expensive. But what we're trying to do is maybe provide them with the quantity of drugs that they require only till they arrive in India. And once they get to India, the prescription is provided by my Indian colleagues. And there, I believe that it may be a little bit less costly. So we're trying to mitigate the cost by making sure that only a smaller amount is bought here. The rest of it is bought in India. And the ones that are bought here will be privately. If they're going for treatment with donor egg, then of course they need something called HRT to start over here, which again will have to be sourced privately, not through their GP, unless they're already on HRT for their own health. Then we can provide them with prescriptions again until they arrive in India, and the rest of the drugs will be provided by prescription by Dr. Talwar.
I hope this answers the question for Sukhdev Singh. Yeah, okay. Right, so we are coming almost to the end of today's webinar, and so to all the people who joined us today, if you're interested in exploring fertility options in India, the medical travel company obviously makes it easy, and we are sharing the link that you can utilize. We've also shared it in the chat box. The USP of the TMTC, or the medical travel company, is that it's a UK doctor-led care right from the first consultation to then recovery after their return from India. And obviously, we are trying to keep it as cost effective as possible, very competitive. And then there is also an all-inclusive aftercare with 24/7 medical support, with personalized care done in the in the India element of the treatment. The link for the medical travel companies on the slide and also in the chat box. There's one other question, and I think it might be a good idea for Dr. Talwar to take this, or maybe even Madhurima. Ayurvedic medicines might be bad. Does Himalaya Ayurvedic medicine cause side effects? I think it's a difficult one to answer, but if anybody can take this, I think that would answer our last question.
No, it should not. Himalaya should not. It should not cause any side effects.
Okay, so we are endorsing that Himalayan Ayurvedic medicine is of a decent quality. Yeah.
The only thing I would add
Yeah.
here is that, for example, some medications have got substance in it that can, say, increase the bleeding time. So if you're having IVF treatment, I would recommend we'd stop it before you actually go for egg collection, because if they contain warfarin, like Chinese medicines do, they make you bleed more at the time of egg collection. So I would stop it. And if I recommend a supplement for a patient, then I don't want too many supplements in. And whether it's helpful or not to take everything together is, for me, is that either you go one way or you go the other. You can't have both.
Correct.
I would not have both.
I agree with this. I agree with this. So I hope, Shubham, this answers your question. Yeah, okay. So on that note, I thank everybody for attending today's seminar. It was a glorious Sunday morning where I was, pretty cool given how it has been for the rest of the week. I thank the panelists for your very valuable time, and Dr. Talwar in particular. She's in Dalhousie enjoying the Indian summer. But yeah, Bhavika, thank you for your time as well, and Madhurima, of course. And of course, to my back office, Karan, Vandita, Krithvi from TMTC, who have been manning the back office, keeping the technology going. I compliment on all your efforts. And on that note, thank you very much. We have the TMTC. You have added it to the chat box, haven't you, Karan?
Yes.
The website link. Yeah, so it's all in the chat box. Anybody is interested, please click on the link, go onto the TMTC website for more information. And of course, Dr. Rajkhowa would be very happy to, take any questions from you later on as well. Yeah, but do go through the TMTC website for any further information that you may need.
Thank you,
Okay,
Vinita.
yeah,
Thank you. Thank you.
Yeah,
there
thank
are
you
no
so
further.
much. Thank you.
Thank
you
you.
so much.
No, it was very good, very, very informative session. And I hope a lot of the patients who came, I wouldn't call them patients, but potentials, it must have been quite useful. So thank you again.
No,
you.
thank you so much.
Thanks, thanks, thanks.
Thanks.